Sir, should I start, sir?
जी इस्माइल, हिस्ट्री सुनाइए।
Uh, Sir, my patient is 65 years old, housewife, a resident of Peshawar, married for the last 46 years, presented to OPD with chief complaint, lump in the right breast for the last 1 year. This lump was associated with pain for the last 2 months, and there was a discharge per nipple for the last 1 month and ulcer over the lump for the last 1 month. So mainly the four chief complaints: the lump, the pain over the lump, the discharge, and the ulcer, sir. So coming to the lump, sir, the lump was smaller in size. It gradually increased, and in the last 2 months, it has rapidly progressed to the current size. She discovered the lump first time while changing her clothes. This lump is associated with nipple discharge and nipple distortion, sir. The lump was painless throughout, and it has become painful for the last 2 months. The pain is diffuse throughout the right breast, intermittent, throbbing type with no aggravating factors, and relieved after taking medications. Coming to the discharge, sir, she also complains of bloody colored, non foul smelling discharge from the nipple for the last 1 month. There is also a ulcer over the right breast. She developed this ulcer on the areolar region 1 month back, which was insidious in onset and progressive in nature. There was a pink colored, non foul smelling discharge over the ulcer, according to the patient. She does not have any complaint on the left breast. Patient also complains of weight loss in the last 6 months. The exact amount of weight loss is not known to the patient. She also complains of lower back pain since 4 5 months, that is relieved on rest and taking medications. The patient also is having history of family history of CA breast in her maternal aunt, for which she underwent surgery. She attained menarche at the age of 12 years. She is married at the age of 19 years. She is having 4 children. All of them are well breastfed, sir. She attained menopause at the age of 46 years, sir. There is no history of trauma to the breast, no history of fever, no other swelling in the axilla or on the left side of the breast. She doesn't have any history of taking oral contraceptive pills or hormone replacement therapy. She doesn't have any history of exposure to radiation. She denies any history related to chest pain, breathlessness, or hemoptysis. She also denies any history relating to nausea, vomiting, or pain abdomen. She doesn't have any pain in the right shoulder or the left shoulder, and she also does not have any CNS related symptom, that is headache and seizures. Regarding her past history, she is non-diabetic, non-hypertensive. There is no chronic illness in the family such as TB or bronchial asthma. There are no medical or surgical interventions uh, in the patient, and there are no biopsies taken before. The patient is not known to allergy to anything, and she is not taking any medications for prolonged time except pain medications on and off. Regarding her diet, she takes regularly mixed balanced diet. Her bowel habits are normal. Sleep pattern is also normal. She denies any history of any sorts of addiction. Regarding her menstrual history, she attained menarche at the age of 12 years. The cycles were regular for 4 to 5 days with adequate flow. She acquired menopause at the age of 46 years. She is having 4 children. All of them were full term and there were normal SVDs. All children were adequately breastfed, and there is family history of CA breast in her maternal aunt. She underwent surgery for that, sir. There is no history of other malignancies such as ovarian cancer, pancreatic cancer, or other family cancer in the male counterpart such as prostate or melanoma. Summarizing the history, 65 years old postmenopausal lady complaining of painful lump in the right breast associated with bloody nipple discharge and ulceration with weight loss and lower back pain and positive family history of breast malignancy and maternal aunt. No complaints of any swelling in the axilla, neck, and or any other region in the body, sir. Should I proceed to physical examination, sir?
Ji, please.
Sir, on examination, the patient is sitting in chair with both hands on the sides with proper informed consent and a female attendant present, sir. Patient is conscious, cooperative, and well oriented in time, place, and person. She is well nourished with BMI of 22. She is well hydrated and she is afebrile. Her pulse rate is 70 per minute. It is regular, normal volume, and in character. Her blood pressure is 120 by 70 over the right arm in supine position. A respiratory rate is 18 cycles per minute. There is no pallor, icterus, clubbing, edema, and there are no generalized lymphadenopathy. Coming to local examination of the breast, the patient was adequately exposed from neck up to the waist and examined maintaining proper privacy in the presence of a female attendant. On inspection, patient was inspected in sitting position with arms by the side, raising the arm above the head and bending forward position. Coming to the left breast first, the left breast is globular in shape. It appears larger as compared to the right breast. The skin appears normal. There are no dilated veins, scars, ulcers, or sinuses seen. The nipple areola complex appears normal. Coming to the right breast position is slightly displaced laterally. Laterally, it is shrunken as compared to the left breast with altered contour. There is a visible fullness behind the nipple areola complex and also in the upper outer and inner quadrant. The skin over the swelling is reddish in color, and there is visible dimpling and puckering of the skin. The poddy orange appearance also noted on the swelling. On raising the arms above the head, the dimpling over the breast appears to be prominent. The nipple is displaced upwards and outwards and deviated to the right, and it seems to be retracted with no discharge, sir. The areola is dark, edematous, and red in color, with the ulcer in the perialveolar area. The ulcer is present at 8 o'clock position. It is 2 into 3 centimeter. The shape of ulcer is irregular. The margins are well defined. The edges are everted. The floor is red with minimal slough with serosanguinous discharge. There are no visible swelling on inspection of the axilla and supraclavicular fossa. On bending forward, the right breast fell forward less than the left. The nipple retraction is also noted. Inspection of the arm, thorax, and shoulder joint. There was no edema of the arm. Chest did not show any other nodules or ulceration. Movement of the shoulder joint were in full range and painless. Coming to the palpation, the left breast is soft, no warmth felt, no tenderness, no lump was present, no discharge from the nipple or areola. The right breast, it was warmer as compared to the left and non-tender. There was single lump palpable behind the nipple areola complex, also involving the upper outer and upper inner quadrant. The size of the lump was 6 into 7 centimeter. The margins were well defined and irregular. The surface were uneven and the consistency was uniformly hard. It was fixed to the breast tissue and the overlying skin. It was not fixed to the chest wall and the pectoralis major muscles. There is a single small round shaped nodule of 1 into 1 centimeter that was possible in the palpable in the lower inner quadrant at 4 o'clock position, 3 centimeter away from the nipple. It was hard in consistency. The nipple areola complex, coming to the nipple areola complex, the lump is fixed to the nipple. A retraction of the nipple is noted. There was a non-foul smelling serosanguinous discharge from the nipple. Once the nipple is compressed, the discharge is even more pronounced. The areola is thickened with multiple small nodules. Uh, one nodule, there is a visible ulcer, 2 into 3 centimeter, that is present at 8 o'clock position. It is non-tender. It is having serosanguinous discharge and which is not foul, non-foul smelling. The floor is red with minimal slough. The edges are everted. The margins are irregular. Coming to examination of axilla and lymph nodes, no lymph nodes were palpable in both axilla and the neck. Coming to the systemic examination, the patient was conscious, oriented in time, place, and person. Coming to the chest, it was bilateral, normal vesicular breathing with no added sounds. The abdomen was soft, no guarding, no tenderness, no rigidity, no organomegaly, no distension was noted, no evidence of free fluid in the abdomen was appreciated. Her PV examination and PR examination was done by the duty female nurse, and she told me that it is normal. Examination of supine position, examination of the spine, it was normal appearing with no restricted movements. So based on my history and
No,
examination, sir, sir,
no. You stop over here.
sir, sir,
And let me give you your feedback. I think it's a very
sir,
good
sir.
history,
Thank you,
very
sir.
detailed and everything it is. The only thing to remember is all depends upon the examiner, whether he
Sir,
wants to hear the complete history or he may not wants to hear the complete history. And the
sir,
reason is since the time is 15 minutes for the history and 15
sir,
minutes for a discussion also in 15 minutes. In 15 minutes, not only history and this thing is to be told, the questions are to be asked also. So what the
sir,
examiner can do is, he may stop you anywhere and may say, okay, just tell me only positive points. So then you shift only to telling positive points. And
sir,
that is the only thing you should keep in mind. It doesn't mean that
sir,
you're not giving a history properly. It is to save time.
sir.
The examiner might say something like that.
Right, sir.
He can also use this word, summarize the case. Forget about it, tell important points. In this case, the important thing to remember is when he is saying positive or saying these things, so you have to mention all important positive as well as negative points in history and clinical examination relevant to the case.
Sir,
So that is one point. Other thing is that now I'm asking you questions now about history.
sir, sir. Sir.
Why do you say her BMI is 22?
Sir, because I calculated her BMI,
How?
that is weight in kgs divided by her height in meters square, sir.
So what was her height?
Sir,
What was the weight?
now I forgot the height. Sir, I
What I
just
mean to say is,
calculated the BMI.
no, what I
Sir,
mean to
sir,
say is, okay, if you are giving
sir,
such calculations, so then
sir.
you must write when you're taking history, what is the height, what is the weight?
Right, sir.
And other thing is that possibly, although it's perfectly okay if you're telling the normal breast first in examination and then telling the breast which has a disease,
Sir, sir.
but it might be a good idea you concentrate on the diseased breast first and then the normal. There's nothing, what I mean to say is both are perfectly okay. Whether you tell
Sir,
diseased breast first and then the other breast, it could be my personal preference because to give disease first, but it doesn't have a more than this merit discussion.
sir.
In chest wall examination, you told this thing that the muscle is not attached to pectoralis major and not attached to chest wall.
Sir.
So why did you specifically mention both?
Sir, to know the extent of disease.
What's practical implication of this?
Sir, from practical point of view, sir, if it is attached to the treatment patterns are changes, sir. If it is, for example, if it is stage 3 or stage 4 disease, at front we go for new adjuvant therapy,
That's
or if it
perfectly
is
okay.
stage 1 and
Perfectly
sir,
okay. So
sir.
in stage 3, the tumor, if it's growing deeply, it will involve which structure? Or which it is going to involve chest wall, or it's going to involve pectoralis major, or both?
Sir, it can involve both, sir. Um, it can involve the chest wall and pectoralis major both, sir.
So when you will call it stage 3?
Sir, when it is involving the chest wall, sir.
True. That's the only point. If the
Sir,
tumor is fixed to pectoralis major
sir.
and not to chest wall, it is the fixation to chest wall which constitutes stage 3. That is what I wanted to make it clear. Now, before I proceed further, you see, by the end of examination, you should be clear about two things first. The first thing is, if it's a lump breast, it is a carcinoma, or it's not a carcinoma. First thing. A second thing you should be clear is, if it is a carcinoma, then clinically, is it an early carcinoma breast, or it is a locally advanced carcinoma breast, or it is a metastatic carcinoma breast? Not only this thing, you should be clear in this sense that whatever information which you have got on history and clinical examination, it means on examination, the lymph node which are palpable, then clinically we are presuming that it has tumor. You should be able to tell what is the TNM classification, what is the T, what is the N, what is the M clinically. I'm not talking
Right.
histopathologically, because the final TNM is going to come at histopathology. You should also be able to tell what is the stage 1, stage 2, stage 3, stage 4. So now I'm going to start asking you questions in the same sequence. Okay. So what do you say? Do you think this lump is, what's your provisional diagnosis?
Sir, malignancy of right breast, sir.
Okay. So why do you say it is a malignancy?
Sir, first of all, her age, she is 65 years old. Second, she is having family history of the CA breast. The third, she is having a visible lump, and the lump is larger in size, that is 6 into 7 centimeter. The larger the lump, the larger is the likelihood of malignancy. There is skin nodules 1 into 1 centimeter. There is also ulceration, and there is bloody discharge. So basing on these positive things, I think this is my provisional diagnosis is CA breast, sir.
Very true. It's a very good justification. बिल्कुल ठीक है. Now what, now I'm going to give you, discuss a little bit this. So therefore what you have told is a lump is going to be malignant in history if there's a history, age is more than 40 years, if there's early menarche, there's late menopause, if the children born are less in number, if there's no history of breastfeeding, and there's late birth of first child, oral contraceptives, estrogen containing, that is important, breast cancer and other breast history, family history of breast cancer, family history of genital cancer. And if the lump is in upper and outer quadrant, it is hard, it is fixed, it's a fungating mass. If skin changes are present, any, it may be putty orange, nipple areola changes, tearing, ulceration. If axillary lymph nodes are palpable, and there's a nipple discharge, which is of red color. So from these, the points are picked up. And these are told, okay, on this basis, we are saying that it is a carcinoma breast. So that's a correct diagnosis.
sir.
Now, what do you think? Which type of clinically carcinoma breast it is?
Um, type means sir tubular or lobular, all these cancers, sir.
नो, आप देखिए मेरा सवाल सुने तो मैंने कौन सा लफ्ज इस्तेमाल किया?
Type, sir.
क्लिनिकली.
Clinically, sir. So it is, I think it is locally advanced breast cancer.
So you say it is a locally advanced breast cancer. And why do you
Sir.
say it is a locally advanced breast cancer?
Sir, because there is skin involvement, there is ulceration, there is a skin nodule. The tumor is fixed to the skin, sir. So that's why, sir, I say this is locally advanced breast cancer, sir.
So therefore, it's very easy to tell it's a locally advanced or not, because if you know the criteria of locally advanced, then either it is early or it's metastatic, and it is very rare for an early carcinoma to be metastatic. तो बात आपने सही की. Any tumor, if you see, which is involving the skin, or it is fixed to the chest wall, or it has axillary lymph nodes, irrespective of the size. If the axillary lymph nodes are matted or fixed, then this is a metastatic, this is a locally advanced carcinoma breast. So my next question is, what's the TNM classification of this?
Sir, since the skin is involved and there is a skin nodule, so it is T4B. There was no node palpable, so N is 0, and on examination, on history and physical examination, I couldn't find out any metastasis, so M is 0. So based on this, it is T4B, N0, M0, which is equivalent to stage 4B, say stage 3B, sir.
Let me revise for you those who आपने सही बताया. So T1 is 2 centimeter, T2 is 2 to 5 centimeter, T3 is more than 5 centimeter, and T4 is extension into the chest wall or skin. N0 is no lymph node, N1 is mobile axillary lymph node, and N2 is fixed or mated lymph nodes. M0 obviously is no mets, and M1 is metastasis. Now, since you have told the TNM classification, you have said it is T4, N0, M0. So which stage it is falling?
Stage 3, sir.
Stage 3.
Stage 3B, sir.
Stage 3B.
Sir.
If you find it difficult to remember A and B, then don't remember it.
Sir.
Nobody is going to
Right.
fail you if you don't tell A and B. But if you broadly do not know T and S of common, then that is definitely something to be looked upon. That why so common tumor one doesn't know this thing. Let me revise for you now. T1 is tumor size is of 2 centimeter or less and without lymph node involvement and metastasis. T1, N0, M0 is stage 1. And T2 is tumor size is 2 to 5 centimeter without lymph node involvement or metastasis, or irrespective of the size of the tumor, mobile axillary lymph nodes are present. Meaning by the tumor may be less than 2 centimeter, but if mobile axillary lymph nodes are present, it will fall into stage 2. Again, rare cases. Stage 3 ka apne 3 bataya, you've already told. Irrespective, one is extension to chest wall or skin, straightway it is stage 3, which is T4. Then irrespective of size of the tumor, if axillary lymph nodes are present that are matted to each other, or fixed to surrounding structure, which is N2, then it will be stage 3, and then stage 4 metastasis is present. So as he has told us, clinically we are talking about, this is a tumor which is T4N0M0, if I'm recollecting correctly, and it is falling into stage 3. Now we are going to the next stage, which is the investigation and treatment. Now what I'm going to do is, I'm going to stop the recording now, and I'm going to end the session, and every one of you please join in within few minutes so that we can continue, because the time is passing, only 6 minutes are left, and I don't want to continue investigation and then take a break. Okay,
Sir.
see you after 1 or 2 minutes.